I'm starting because it's...
Yes, I'm just going to start.
Anyway, thank you all for coming, and I will try to give you some insights on how I think we can improve, or for some of us, how to kick off and start doing some clinical research, particularly in a practice environment. So, I don't know about you, but if I ever lost my eyesight, I would be, basically stop me doing all the things that I really like doing. So I rely on it, I trust it, and I don't often get misled. Even I can recognise some old classmates from years ago, and I occasionally remember the names of my children, things like that, through sight. But we sometimes use the expression, I'll believe it when I see it. So I want to ask you, we've got two squares in this picture, and it's obviously going to turn out to be an optical illusion, so don't double think it. Square A here and square B. So put your hands up if your eyes are telling you that those are the same shade of grey. Okay, no, that's right. I so much like it when everybody behaves. I gave this exact example to some medical students at a lecture about a week ago, and about half of them put their hands up, just to prove that they were good. So I've got an experiment here. So I've actually got some grey. Oops, what's happened to this? Where have my grey bars gone? What's it done to it? It worked I've given this is the second time I've given this talk, and it worked. The bottom line, okay, is that what normally happens is I have animated, if we had a proper computer, there are two bars down the side that are animated, and they're a shade of grey, and they move in to the side, and they demonstrate that shade of grey is actually exactly the same as that shade of grey. This is purely an optical. It's a very good one. It's the best one I think I've ever come across. But the point I'm trying to say is that we rely on our eyesight, and you can't even trust your eyesight. So, we're very poor at judging risk. We're very poor at judging numerical things. We're easily misled by things that require statistical understanding. So, the premise of doing research is to search for the truth, because what is obvious, in inverted commas, isn't always true. So we follow scientific method, and since the sort of Enlightenment, people have sort of been developing a rational and sort of hypothetico-deductive sort of reasoning technique. But the one that I quite like is this quotation from Einstein, which is, "No amount of experimentation can ever prove me right. A single experiment can prove me wrong." And it's really highlighting the importance or the essence in scientific method of testing. If something cannot be tested, in other words, we can't do an observation to show that it could be wrong, it doesn't work. Now, generally what we're doing when we do a clinical trial, although it always seems like we're showing that maybe one drug is better than another, we're starting off with a hypothesis that there is a difference, say, between two treatment regimens, and we will disprove it if we find that they're the same. And for me, it's generally holding an open mind. So let's just think about an example. So this is we might be thinking we're getting a lot of treatment failures, say, with our cats with a particular disease. Maybe it's just use of antibiotics. And somebody might suggest that actually one of the problems isn't so much the disease or the treatment, but we're trying to give these cat owners pills the size of suppositories, and they're having difficulty putting them down the cats, and that maybe what we should be investigating is compliance. And this will be too difficult for you to read, this is one thing I know when I teach people to lecture. It's never apologise for your audio-visual aids, but obviously this one's been completely ruined by this computer system. The point is, you come up with an idea. You've basically got a hypothesis, which is, do all the cats actually get their medication? We decide we want to test this. We might do a client survey. So we send out a questionnaire to our clients. We get them to fill out the questionnaire, which generates our study findings. We infer from that what is actually happening in the study. And generally what we're doing with most clinical research is providing something which our colleagues can then extrapolate to the use in their practices. And what sort of things can go wrong? Well, straightforwardly, if we ask really stupid questions, if we ask ambiguous questions, if we say, word it like, it's absolutely essential that you give your cats the pills, did you give all of yours? They'll probably be pushed towards lying about what they're doing. And of course, they could just lie anyway because they recognise that you want them to say that you gave them all the pills. We could have selected the actual clients wrongly. We might have just said, we only give them to we only gave the questionnaire to clients who are nice to us and always answer us, so we don't actually get the full reaction. Something could go wrong in as much as we could purely by chance actually get all the clients who are really good clients and will comply. They're the only ones who actually got the questionnaires because the receptionist said, oh, they're not very nice, you don't let them fill the form, or they're not very helpful, we won't let them fill the form. So there are loads and loads of different things that can go wrong from having an idea, going all the way around, doing the work, and then finding out what the universal truth is. And by far and away, the most important or the most difficult thing in research, and actually it's true of all research, not just clinical research, is actually asking the right question. It's actually, a good research isn't about designing experiments, it's about knowing which question to ask. And so, for example, if we were worried about treatments not being effective and we were thinking it might be client compliance, actually it could be a whole load of other things. It could be we got the diagnosis wrong. Actually, we could be just giving the wrong treatment. It could be that cats are very good at spitting out pills a finite amount of time after the owners have given them so that they don't witness it. There may be differences in preparations or drugs that are giving, timing of the dose, all sorts of other things. And we want to consider those as potential confounders that may bias our result. And some of the times we don't mind about them because they represent the real world situation. At other times, they will get in the way of us actually coming up with a meaningful answer. And what we would generally do, that would generally go through, is a sort of refining process in getting the question right. And we don't want a question that's either too wide, too broad, or too narrow. We might, in this particular instance, say, rather than talk about all cats and all pills, because that means there are lots of different flavours, lots of different presentations of pills, we'll choose a specific disease and a specific treatment. So variation in the health of the animal and variation in treatments are eliminated. We then might want to say, well, what actually is the best outcome to measure? If you're looking at something like diabetes or type 1 diabetes, and you're looking at insulin deficiency, you'd probably be most concerned about actually were they getting the effective physiological sort of treatment. So you might want to look at insulin levels or sugar levels. But questioning the owner is not a bad one, but if you think there's a lot of scope for people not necessarily telling the truth, or clearly if you anonymise the questionnaire, that would help. You could give them a fixed number of pills at the beginning, which is more than they need, and actually count the ones that returned. You could use an intelligent pill pot, so they now make electronic pill pots they use in human compliance studies that actually measure what's taken out of the pill pot and when it's actually done. So you don't get this sort of, and I have been known to do this with my own pets. So I put the animal on a course of something, it's better, and I'm sort of, it clearly doesn't need them anymore. But my wife thinks that I should finish the whole course. So what I normally do is I get to it and I think, well, I'll just chuck it in the bin. So they do get taken out of the pill pot, they just don't end up going down the cat. I mean, I have fingers too, and I won't be able to play the piano like a concert pianist if they're ragged and torn. So we want to refine the question. And in this case, what we might do is then say, what our research question is going to be is for all cats prescribed a course of oral antibiotics following elective surgery over a 6-month period in 4 collaborating veterinary practices at Cambridge, how many received the full course as reported by their owners in an anonymous questionnaire. And that then dictates the design of the study. And this is very similar to this PICO acronym, so it's generally structured in a very similar way. One of the things that I wanted to say is that what I sometimes tell people who are having difficulty formulating the question is say, fine, don't decide on your question now, start to design the study, but the study and the question must both be finished before you actually do the research, so that you can then cross-reference, is the study design actually answering the question that you're trying to answer? The reason that I'm slightly stuttering is because I overran when I gave this talk before lunch. So obviously over lunch I knocked out a few slides because it catches you out because you're then expecting a slide. There's this acronym FINA, which has been proposed in a number of textbooks as a mnemonic for formulating a good research question. And the F stands for feasible. And there's no point trying to do a study on an extremely rare disease, so it's going to take 20 years to accumulate enough cases. There's no point in asking your practice to buy you £400,000 worth of imaging equipment because you need it for this particular study. So feasible both in terms of patient availability, expertise, affordable and manageable. Interesting. The only person the research really needs to be interesting to is you, if you're doing the research. But on the whole, if you're trying to sell it to other people, then being interesting does help. The one that shouldn't be in FINA, so it should really be FIRE, is novel. And that's straightforward for clinical research. So if we never repeated a study, all it would take is one study to be published that had a positive effect or had a negative effect, and then nobody would ever consider using that treatment ever again. Clearly, that would assume that the person who did it the first time got it right and that nothing ever changed. So every study actually is intrinsically novel because it's performed on a different population of subjects. And particularly for practitioners, bear in mind that much of the clinical research is done in vet schools or on laboratory animals. They're a completely different population of animals than is generally come across in general practice. I'm going to come on to ethics in a minute, but there's one very simple rule about clinical research. If you would not be prepared to do it to your own children or your own animals, then you shouldn't be doing it on other people. So don't abuse your patients or your clients. And relevant. Again, relevance is if it's interesting to you, then it's relevant. But there's one aspect that I try and push time and time again, and to people sort of asking, can I help with a particular project, or can they go through their ideas with me? And one of those is saying, well, if you had this information, would it be useful to a colleague in making a decision about a patient? So if it means you're saying, yes, I'll show them that this diagnostic test is actually a bit better than this one, or this treatment's better than treatment, then I think by definition it is relevant. So there are a number of aspects to study design that need to be considered in the planning process. And a really important one is case definition. Case definition is essential, and it needs to be objective and reproducible, because essentially if somebody else can't do your study, can't repeat your study, then it's a fundamentally flawed study where you can't describe it. So we want to have a case definition that anybody else with a similar level of training and expertise could follow. In a perfect world, say in cattle upper respiratory or respiratory disease, you would get a PCR or virus isolation to confirm that the cases had RSV or whatever it happened to be. But it's important to appreciate that case definition should sometimes reflect the real world situation. So if we're talking about cattle respiratory disease, if you go through the clinical signs, that would lead the average practitioner to embark upon a treatment plan for upper respiratory tract or lower respiratory tract respiratory disease, then actually in some ways that is appropriate and useful. So there are times when drug companies are forced to go for very strict case definitions, but for clinical, if that's the population in your hands that would have received that treatment, then it is appropriate to use it. So it is, but on the whole, we're looking for an objective definition that in practice would define the animals that would receive this intervention. Ideally, a definitive gold standard diagnostic test. Outcome measures are another area that people have problems with, and that reminds me, I started at past, didn't I? Yeah. The thing that we measure is important. So the majority of projects that come to through my hands normally involve me saying, what's the question you're trying to answer? And the response comes, we were interested in X disease, and we have collected data on A, B, C, D, E, F, G, H, I. And that's really, you've got multiple potential outcome measures. It makes analysis almost impossible. And half of those parameters are of academic interest, but actually aren't really outcome measures that really matter. What we really want to know is what's of interest or what's of significance to the patient or the owner of that patient. Most of the time it's, is that animal better? Is that horse returned to use? Is my dog enjoying his walks now? Able to do a full walk? Yes, we'd like them, if possible, to be objective. It's really lovely. I've just finished a study on hypothyroidism. It was lovely. We took blood samples, we took it to the lab, they gave us a number, okay? And that number, if we got 20, whatever it was, 20 is definitely twice as much as 10, okay? It's simple in statistical terms. There are things like pruritus that can be tricky. But actually, in some ways, I don't think it is. Because if you have a really itchy dog, then as an owner, that's what you want to get. You don't want to watch television and constantly be distracted by this dog scratching away in the corner. You don't like finding all these bits of sort of scratched off skin and hair in the corner of the living room. So probably a question that says, is your dog scratching more or less, is appropriate, is relevant. But there are other things that we could do. We could video the dogs. We could score self-excoriation lesions. We know that the pruritus is probably being generated by catecholamines or degranulation of mast cells, and so histologically we could also grade the pathology. So we have a number of choices, but actually for straightforward in practice clinical research, getting simple subjective assessments is fine as long as you use them consistently. It means they create more variation, but they don't generate false information. Lameness is another one. We know that some vets, so when Graham was at vet school, he was renowned for having a very fine eye and being able to spot lameness almost as well as experienced horse vets, whereas I would need a three-legged donkey before I'd recognise that it was lame. Obviously, experienced horse vets are very good at scoring. They'll score consistently, and if you take a number of them, they'll probably score equally well. But whereas other people don't. And other aspect of it is that it depends on what the horse is used for. So what is severely lame for a dressage horse might be completely acceptable and normal for a sort of riding school hack. So using subjective methods of scoring are difficult, and people sometimes video them and do them anonymously and get panels of people to score them. And what, of course, the orthopods do at vet schools is they get lots of money for a thing called a force plate that enables them to actually measure imbalances in the gait. Both could be appropriate in the right case, and as I say, probably though, if I'm talking about 2 surgical procedures or something, treatments for navicular, the thing that I care about most is, was this horse back in work 6 months after the treatment was begun? I didn't mean to do that. Now I have to do next. I could press escape, you are right. Hate pieces. True. Right, next thing, sampling. So obviously in a perfect world, if you're doing clinical trial, you get every single animal in the world and put them in the study, and the ones that didn't have the disease would be the negative controls, the ones that did have the disease would be your study group. You'd have an absolute truth in the world. But we have to sample, and we can't do a census. So generally what we're doing is we have a target population. So it might be typical, you want to, in many ways, make your target population relevant to your practice or to a general practice in, say, the UK, which means that you want to ensure that the right breeds and the right ages are represented. From what is the target population, you're going to identify a source. So you have what you have available to you, which will be the animals that come into the clinic, come into your practice. And it's, again, one of the reasons why practice-based research is so much more valuable and so much more important. Because what do we get in vet schools? We get very much loved, animals from people who have lots of money, can either spend a lot of money on insurance or pay for the treatments, and they do not represent any sort of a normal population at all. So, and when we're looking for negative controls, we do things like get blood samples from orthopedic elective surgery cases, because they're most likely at least not to have a medical problem. But in practice, you have much better access to much more relevant populations. And then from the ones that are available, you pick a sample. And the main issue is the animals available to you relevant to the whole of the UK or the whole of the world? It's possible if you run a cat referral practice in Kensington, you may not have a typical practice population, even if you were to sample it correctly. Whereas in Godalming or Swindon, you're probably more likely to have an average, and you did general practice to have an average representative population. And then once you have, when you choose those, if you only choose the clients who are friendly, or you only choose the clients or only one of the vets who has a very good bedside manner is responsible for doing the research, you may not sample truly randomly from within the available animals. And those two issues, in other words, is the source populations. Your practice, a typical practice, is to do with external validity. In other words, can I extrapolate from this study? And if you don't sample properly randomly within your practice, then you have a problem with internal validity. So people talk about internal, external validity. And the main, so to talk about sampling and this magic word randomization that I've been going on about, we love randomization. It makes life so much easier. It means that if you use a truly random way of picking animals, then you will end up with anything that may be a confounder or be a source of bias will be equally distributed into your groups. And what people tend to do is use other ways. The classic way is arbitrary, which just means, well, I didn't use any particular method to choose them, so it must be random. No, arbitrary isn't the same as random. They then use judgmental and say, well, look, I didn't choose that client because their animal isn't normal. So you're clearly going to bias. And of course, unconsciously, we will tend to, there's a great danger for introducing bias. Sometimes you do have to bias. And so you might have to say, we need to only look at animals that have been exposed to disease. So we need to say, choose cats where there's already been a case of FELV or FIV in them. So simple. And what annoys me when I'm reviewing papers is that people will not just toss a coin or do one of the very simple methods that you can use to get a random sample. They seem obsessed sometimes that there should be an equal number in each group. And of course, if you truly choose randomly, you can end up with an unmatched groups in terms of size. If matching the groups on size is important for cost reasons, then you have to work a bit harder at your randomization. So there are times when we will be partly round, so there's a systematic round. If you've only got resources to process one subject a day, then obviously you just take the first case that comes in that day and assume that there's no particular reason they're bias associated with people who book appointments early rather than book appointments late, but of course it could be a source. And sometimes we deliberately stratify the sampling so that we have equal age groups represented or equal breeds represented. And that's just to eliminate a known potential bias or confounder. Press the button again. What did I do there? I meant to press the key. Not that it matters. I should just press this. Right. So we've already talked a bit about where the patients come from, and I've already anticipated my own slide by talking about vet schools not necessarily having typical or representative populations. Rescue shelters, RSPCA clinics might be another source of a convenient source of patients, but might introduce bias. One of the, I know I ranted on just now about not wanting people to collect a lot of data. There is a good reason for collecting information about breed, sex, weight, and things like that, because they provide you with demographic descriptors of the animals that were in your sample, and that enables people to compare what your sample looks like to the animals they work with. So if you have a ridiculous number of pedigree animals or you have no pedigree animals, it would show up in the distribution of breeds. Another area that sometimes causes more consternation in the authorities than actual examples of people doing things wrong, but this concept of avoiding the Animal Scientific Procedures Act. So, as you know, work on experimental animals is covered by the Home Office, or dealt with by the Home Office under this Act. There is very clear and very good advice in an appendix to the RCVS Guide to Professional Conduct, and it's pretty straightforward. And that is, if you are going to do anything to an animal that might cause pain, suffering, distress, or lasting harm, and it is not directly for that individual animal's benefit, then you are not allowed to do it. Okay. On the whole, though, given that there are many conditions where there is no single treatment or single diagnostic technique that is head and shoulders above the others, or that there are times, is that most of the time the things we're interested in is when we don't have enough information to know what is the best way to use. It is perfectly reasonable you are allowed to run a randomized controlled trial, decide to use 2 treatments, neither of which would be considered unreasonable by colleagues. And my biggest complaint, I didn't say this in the last talk, so I get to say it now, is placebos. So I'm a great believer in the placebo effect, even for animals. And I also think there are lots of cases where we do, our colleagues are keen to intervene when I'd be quite interested to know if the intervention was any better than a placebo. And yet, if I were to say to the Royal College of Surgeons, can I use a placebo? I'd be told no, that would involve withholding treatment from an animal that should be treated, which I think is fair enough. Now, okay, for some of these things, say if I were doing a probiotic study, people would say, well, whether you gave a probiotic or you didn't give a probiotic, that withholding that treatment would be reasonable. But interestingly, I could have a cat with kidney failure and say I wanted to compare the use of some essential drug. That's so long ago, I can't remember what you could do for a cat with kidney failure. But if something severe, anyway, I could. Tell you what I would be allowed to do. If I wanted to run a clinical trial of comparing surgery for pyometra versus homeopathic therapy, that would be fine, because homeopathy is an active veterinary surgery. So I'd be allowed to do it. Now, I'm pleased to say that I don't think any homeopathist would be mad enough to do it, but I have had discussions about this sort of thing in the past. But that's one of the anomalies. But you can say, my advice, if you want a negative control, just use a homeopathic treatment. What's the worst that happens? You show that the homeopathic treatment works, and that way you opened up a whole new area of research and understanding, that would be good. May not happen, but...
Buy a lottery ticket while you're at it.
Anyway, why don't we what?
Buy a lottery ticket while you're at it.
Yeah, you see, a lottery ticket wouldn't be an active veterinary surgery, so I'll be withholding treatment. A question.
Would you be allowed to compare treatment to no treatment, where the owners make the choice that could be based on finances or other factors? So you're never withholding the treatment, but some animals don't.
Conceivably, I've done in the past, I have run a placebo in hypothyroidism in cats. And that would be one that's tricky because, withholding, euthyroid treatment in that case is tricky. But what we did was we had a slightly different case definition. So we said if thyroid levels were above a certain level, we accepted that there is often a delay between initial diagnosis and surgery. And we went no longer than would be considered. We did extra monitoring. So I think I would be reluctant to say an individual one. But what I'm going to do, when I get back to that slide, is say, this is what you do. All clinical studies should go through ethical review. All vet schools have an ethical review panel. If you email me, I'll put any practice-based projects through the Cambridge ethical review process. Another way of getting ethical review is just to find someone in the vet school who's willing to collaborate. And in my experience, if you say to someone, would you collaborate? All I need you to do is to put this form through the ethical review committee. No other work is required. It's funny how keen they are. I'm being cynical. They'll often give you useful advice and help the clinical research.
So the Royal College will do it as well?
I don't think it will. At least it wouldn't last time I inquired. Have they set up an ethical review committee then?
Or you send things through and they will comment on them?
I think they'll comment on them, but I don't think it's a formal ethical review process. I think they take one person and they just get them to look at it. Do they give you a reference number to refer to when you publish? Yeah, I mean they are helpful. I mean they try and be helpful. But I can remember I was sitting on the panel that rewrote the appendix last time, and it was amazing how many people in vet schools stood up and said we're not going to open up. We're not allowed riffraff to use our ethical review panel. They'll be overwhelmed with work. We've got more important things to do. I get about 3 requests a year. It's not onerous, and the Royal College specifically were very unkeen because of the expense. So obviously you've got to pay people to do, you've got to eat and you just pay them. But I may be out of date, so I shall make inquiries. And actually, remember, you can always ask the Royal College for advice anyway. Statisticians. So I told this statistician joke in the last lecture, and only one person laughed. So I'll test it on you. So it's my favourite mathematician joke. How do you tell a socially well-adjusted mathematician? They look at your shoes instead of their own. There you go. See. It's worth a titter, I thought. Anyway. Why not speak to a statistician? I hasten to add that such crude generalisations are offensive in every possible way, and I apologise to anyone. My son is a mathematician, so I feel justified. Where do we get to? Why not speak to a statistician? It does no harm. They're generally extremely pleasant people and they can save a lot of time. And when I say statistician, it doesn't really have to be a card-carrying statistician. I'm not a statistician, but I like to think people like me, been around the block a few times and have a basic knowledge of arithmetic and sort of some statistical principles can probably point me in the right direction. It's much better to do it before the study rather than after. But there are 2 really important things that they help you with. One is how is the data going to be analysed, which is less actually important compared to how many subjects do I need. But when they go through how is my data going to be analysed, what the statistician quite often does then is actually point out fundamental flaws in the study design rather than problems with the statistical review.
And the other thing a good statistician will do is if you're working on retrospective data.
Never work on retrospective data.
Yeah. A bad one will just say, well, we can't do that with the data available. And the good one will say, that's a challenge. Let's see what stats we can do with that data available. Yeah,
for big projects, and particularly retrospective, a statistician from the outset is a good idea. It can save you a lot of time ferreting about for information in dusty old records or computer archives. But I agree, that's a good point. But one of the things that people have a lot of difficulty with is saying, how many animals do I actually need in this study? Okay, and there are two pieces of information that you need to provide or obtain. One is the difference that you want to be able to detect. So let's just say I was looking at a surgical procedure that works 80% of the time, and I think there's a new one that might work better. How much bigger than 80% are you interested? If it was 80.1% as opposed to 80%, would you care about that? Yeah, because that's pretty well 80%. If it was 81% as opposed to 80%, well, if it were true, I suppose it might be. What I'm really looking for is something that's probably 85% or 90% or 100%. It needs to be at least 5% different. That size of the smallest difference you want to detect is important. The other thing you need to know is how much does it vary by? So some things like blood pressure, for most animals, resting blood pressure for an individual probably doesn't vary much from day to day, from hour to hour, until if it's not exercised. Other things like somatic cell count in dairy cows, a number of neutrophils in the milk, can vary enormously even in healthy individuals. And the more it varies, the bigger sample we need. So a couple of graphic examples. So if you're trying to have a study that can detect the difference between, say, that mean and that mean, so a very small difference, okay, you're going to need a large sample. You can see how many of these individual readings are overlapping with the individual readings. The top one's up and the bottom one's up, but the mean is up, but they're overlapping a lot. If you had this situation where you got a big difference, you've got, it's very easy to detect that difference, so you need less animals. And similarly, if you get to two populations, this is where you've got high variance, a lot of spread, a lot of you get some very low readings, some very high readings, as opposed to this population with a low variance, where they're all quite tightly clustered around. Where there's not much variance, it doesn't interfere too much, so you need a smaller sample of animals, and in this situation, you need a bigger sample. And it's pretty straightforward. Okay. There's one very fundamental reason why it's worth doing it, quite apart from the fact you don't want to waste your time, not getting a result with too few animals. And that is, if you fail to find a statistically significant difference and you have an adequately powered study, in other words, you've done the sample size calculation, it means you can interpret the negative result. It doesn't mean you can interpret that result to say there is no difference. But what you can say is there is no difference bigger than, okay? And in an underpowered study, when somebody hasn't done a sample size calculation or done a post hoc power calculation, and they sort of say, they did tested drug A versus drug B, there was no statistically significant difference, therefore both these drugs could be used equally. That is false, that is untrue. In an underpowered study, you just didn't have enough animals in the study to be able to reach any conclusion. So it's important. Anyway, did I? Yeah, I've got an example. Do I care about that? Oh yeah. So I've got an example here I just want to run through. So let's just say we did a pilot study. And we're looking at whether tail-based sensation in a cat actually is a good prognostic indicator. So if you pricked a cow in the tail person, you had and it actually responded, then you'd hope that was a good prognostic indicator, and indicate that even though the cat may have been incontinent immediately after the road traffic accident, but 3 days later, hopefully it will regain bladder control. If you don't get tail-based sensation, that might be a poorer prognostic indicator. And that was borne out by our initial pilot study. We found that 11 out of 11 cats that had tail-based sensation following a road traffic accident, they regained bladder control within 3 days, but only 4 out of 10 did with if they had no sensation. So those figures weren't statistically significantly different in this pilot study because we didn't know how many animals used. We're using this information to give us to be able to do our pilot study. So we want to prove that 100% is different from 40%. How many animals are we going to need to do this? We use a p-value of 0.05. It's often called alpha for power calculations. It's the thing that represents the type 1 statistical error, which is basically finding a difference where none exists. And it's arbitrarily 0.05. You don't need to understand why. It's not even important that it is. But essentially it's just saying in 1 in 20 cases, you'll actually get a statistically significant difference when there really was no difference. Beta is the chance of finding a false negative result. So it's the beta error, it's the type 2 error. It's essentially failing not to find, finding a difference where one doesn't exist, basically. And what we use there is 0.2, and so we're going for a power of 80%. We're saying we've got an 80% chance of finding a statistically significant difference if there truly should be a statistically significant difference. But it's just all, and you don't need to remember these because all the websites and all the texts and whatever you do will have these down, so they are the conventionals. Does it matter that if you use 21% or you use 0.04? Probably not, but these are the conventions. And you don't need to do anything other than Google power or sample size calculation for a proportion, and you'll find a calculator like this. And you feed in the numbers, and in this case, that's where we typed in alpha, which is 0.05, which is the p-value threshold. We typed in this actually asks for the power rather than the beta error, so that's a case of 80. And they've actually given you a prompt, they're saying it's usually 80. Then here's where we put our two proportions, and they're in as a sort of single number, so that's 1 versus 0.4. And you normally get a chance to say if the groups are going to be biased, so if you have more in one group than the other, but you can ignore that for the minute. You press the button and it spits out this. It says you need 8 animals in each group to make this statistically significant. In fact, if you remember well, we actually had more than 8 when we did it in the pilot study, but that's my mistake. I should have lied and put a smaller number in. This is what happens when you reconstruct something from something that truly did actually happen. Now, you and I are sceptical about what we find on the internet. Our children are always telling us not to be so promiscuous and on the internet and going out and reading things and believing it. So what we do is we choose one of the other things that came up on the Google search that purported to be a sample size calculator, and we put the same numbers in, and that's what we got here. And I put in 0.5 for the alpha, 0.8 for the beta, for the power, and it's and there's the two proportions, and it's chucked out exactly the same sample size. So it's a very reassuring thing. And if you do any statistics, or just want to try some out, you're just reading a paper and just want to sort of think, oh, I want to calculate, check a particular statistic. There are all sorts of internet calculators out there, normally very well documented. And as I say, if you're suspicious of an answer, just try and see if they all agree with each other. So how am I doing time-wise? Oh, I'm already overrunning. You can't have that. Now, I've gone through exactly the same exercise comparing two means. One of the things I want to say is you need to know the variance, okay? And I've told you, and the variance is essentially the same thing as a standard deviation. One is the square root of the other. And you say, well, I want to measure, I don't know what the variance of, say, this particular liver enzyme is. If you have a normal range from your laboratory, or you find a textbook with a normal range in it, that will encompass about 95% of all normal animals. Plus or minus an extent that encompasses 95%, very conveniently covers 4 standard deviations. So all you need to do is to take the laboratory range and divide by 4, and that will give you your variance or your standard deviation. So that's a tip from the pros, as they say. I wish. That's calculating it. Sample size. Yeah. If you have a study that is more complicated than the stuff I've just been describing, so measuring one thing, then you may want to ask a statistician. But actually, a really good thing to do before you go to your statistician is to collect some data. So take some sample data, because they'll need to calculate some variances from it. So that's a good idea. If you, for some unknown and peculiar reason, best known to yourself, wish to do some sort of questionnaire or survey, okay, then apart from my advice, which is don't, my second piece of advice is, if you're going to do qualitative research, go and speak to the experts. So people in political and social sciences have to do qualitative research to address the questions, and they have much greater expertise than the rest of it. There's a very simple reason I don't do qualitative research, and that's because it's difficult to do well, and I'm pretty feeble-minded. And so, you know, questionnaires, you know, a focus and real thought about the question you're trying to answer is important. And I'm being slightly over the top about it, but when you've been through enough student survey projects, or as many as I have, you do end up being a bit cynical. But there is actually one rule of thumb I can give you if you sort of don't have easy access, and that is you need 10 completed questionnaires for every piece of data that you've got on the questionnaire. And that does mean if you can't count one question that has a grid on it with sort of choices up the side and choices up there, that is, if that's a 10 by 20 grid, that is 400 questionnaires that you need return. So when I tell people this, it normally makes them focus a bit and ask the questions they really need the answer to. And that's only for the data you are going to analyse. It is reasonable to collect demographic data, not for analysis, but for establishing that the population is normal. Okay, so how's your data going to be? It really depends on what you're measuring. If you're measuring something that's continuous variable, like blood pressure, then use certain techniques. If you're using counts, proportions, then use things like chi-square. And if you're doing survival times, there is a standard set of tests for doing that. Analysis is generally pretty easy, and it isn't a problem if you haven't seen your statistician before, and if you've actually done a really good study design. It's the thing, chances are, though, that you haven't quite thought of everything, which is why you should speak to a statistician. So before I finish, my reprise is, and this is what I wrote when I first wrote this lecture, and I was sort of sitting in my office and I was sort of just clinically and coldly trying to sort of think of some sort of teaching about this. And I said, you've got to ask a good question. So that seems like good advice. Think hard, plan well to get the design right. And particularly think about how you chose the sample and how many subjects were in your sample, and then stick to that plan when you actually do the study, and don't over-interpret the results. You know, be modest in how you interpret. But on the train down, as reviewing the talk, as you do, I thought, actually, this is the more pragmatic advice, and that is, just go ahead and do whatever it is you want to do with a minimum of interference from anybody like me or anybody else, but do it as a pilot study, okay? You have all the skills, and you certainly have the intellect to be able to have a reasonable first attempt. That information will give you data that could be used for a sample size calculation. You'll go through, you'll rehearse all the procedure, you'll realise how easy or difficult it is to do certain bits of it. You'll realise how helpful some people are, how obstructive other people are, all those sorts of things. Identify those problems, reflect on it, and then just start again with the main study. Because there's only one thing that there's one thing that I really strongly believe about clinical research, and that is the best way to learn how to do it is to do it. And that's certainly how I did it, and it's certainly, you know, why I've been author on some absolutely appalling studies in the past, but hopefully some slightly better ones now. And that's, oh yes, do buy a copy of this book. I can strongly recommend it. Peter Cockcroft's Children Will Be Starving Unless You Buy a Copy. I like Dirk Pfeiffer's short book on epidemiology. I also like, I should have put it on here, Aviva Petrie's written a veterinary statistics book, which is also very useful, but obviously the best one's that one. And with that, I'd like to say thank you very much for listening. And I'd be happy to take any questions. One in the back.
Thanks.
I'll try not to be
Can I
too
just
flippant.
clarify, if you are doing a pilot study and then following up with a full-scale clinical study,
Yep.
does that have to go through two separate ethics committee approvals?
Okay. Do you want me to give the pragmatic answer or the true? So the pragmatic answer is the journal won't care as long as there's some sort of number to put on the declaration. You can take a common sense approach. What I would normally encourage if one was anticipating doing a pilot study and then the main study is to write that a pilot study of this many animals will be performed, and that will determine what the final sample size will be. The final sample size, and I would do a very rough calculation for the sample size and say the final sample is unlikely to be greater than, so that at least the review panel know approximately how many animals you're dealing with. But yeah.
So surely the ethical review is not for the benefit of the ethical review is not for the benefit of the journal. The ethical review is for the benefit of the animals under.
Okay, I'll be pragmatic about it. Okay, of course, ethical. You and I could be sitting around. We should be going to the next AWSELVA meeting or whatever it is. We should be discussing how to improve ethical review and what aspect. Maybe we've been a bit lax on this. The bottom line is that the main reason for a practice-based research project to go to ethical review is to make sure you don't breach the Animal Scientific Procedures Act. I like to think that there's no veterinary surgeon who has been admitted to the college that would do something that was cruel to animals, So I think we instinctively have that. If we don't trust our own judgments in individual cases, why should we distrust our judgment when we're dealing with groups of animals? I mean, that's what being a professional is about. So I think the suffering to the animals side of it, I think we sort of cover mostly. But it is quite easy to accidentally, quite well-meaningly breach ASPA. The reason most of us academics go through ethical review is not because we want to, it's because we have to. The reason we have to is that some journals won't publish unless you've got a reference for ethical review. Do I believe ethical review is a really good thing? Yes, I do, because if we didn't have it, people like me would just assume that I knew what was right. And although I think the majority of my colleagues are in the practices don't need lots of ethical review, the fact that we have it there and it's not too onerous and it is quite practical does mean that it helps, saves us from ourselves. It saves animals from me occasionally, probably saves animals from us, occasionally. But was that the right balance between flippant and being responsible? I should probably have just said, of course, ethical review should always be followed for the greater good of the animals.
Should I have got an ethical review before jumping out from behind a bush and finding my cat?
Yes, definitely.
My leg and jump.
Yeah.
You spent a little bit of time talking about sample sizes in the talk. And obviously, if you read kind of gold standard medical papers and look at the sample sizes in them compared to what we've got to deal with, there's a huge disparity. Do you think that standardised clinical record initiatives, things like SAVSNet, do you see that improving the situation?
Of course it will improve the situation. The very first time that I was involved in trying to standardise records was when I was an undergraduate. And that is sadly a very, very long time ago, because I did computer science as an intercalated degree, and so I was sort of dragged in by some well-meaning clinician, and there was Snowball, I think, running in those days. They will help enormously, and both SAVSNet and is SAVSNet Liverpool one, it is, isn't it? And the London one, what's the RVC one called? Venom coding. Are both what's it called? Pet Compass, that's right. Both superb initiatives, and they'll both improve what we do. But, you guys know, it's like herding cats dealing with academics and clinicians. We can't even get our clinicians in Cambridge to use CRIS, which is a fundamental first step in all of this. And it's not that their fault. It's not that they're objecting it. It's just for a multitude of reasons. But yeah, I think standardised coding and those sort of things would make access to a national health service would be jolly handy too, which is another thing the medics have. Funnily enough, there is one example of the best system, and I mention this name, is Banfield, because Banfield have a unified medical recording system that covers the whole of the United States. And interestingly, it's better quality data, national data, than the human data, because there is no connected human surveillance data for anything other than the ones that are sort of federally regulated. Good. Oh, one last question. These people have suffered enough.
No, I'll keep it brief. Perhaps not flippant. You commented that you think that studies should be repeated.
Absolutely.
As a reviewer, how did study repeats across your desk, and of those, did any of them actually make the press?
None, I can honestly say, that I'm really consciously aware were a deliberate repeat, because often they repeat part of a study and not the whole study. But I have had experience of doing one and having some absolute comments back from a reviewer saying that this should not be published. It is a repeat, in those, which shows such devastating ignorance in a reviewer that what makes me sad is not so much that a reviewer made the comments, but the editor didn't even notice that they'd made the comments. And I suspect one of the problems is that editors very rarely actually read the comments of reviewers. They just sort of pass them on. That's mine. If you were there at the EBM conference, whenever it was in London, was it last year? I had a big rant about reviewing and editors, so I'm not going to repeat that now, but if it's recorded, you can catch it then. Okay, and this is the last one.
Yeah.
Right.
I was just going to say, the associated problem of getting anything with negative results.
Yeah, so one of the other big issues is that, particularly for research synthesis, because we only tend to publish positive results, you end up with this problem called publication bias, which means that if there's something that has a partial, is not very strong effect, all the negative ones, because they actually give a negative result, and people get an impression that actually there's much more evidence that something works than is truly justified. So it really is important to try and persuade people, and I think it will change in time, because we're going to get more and more open access, internet-only publications, and that's where at least we'll be able to find a home for our poorer study. Anyway, that's it. I think at that point we'll draw it up. I think I've bored you enough, but thank you very much for coming.